Welcome to the module on lymphomas. My name is Karen Fancher, and I'm an Associate Professor of Pharmacy Practice at Duquesne University School of Pharmacy in Pittsburgh, Pennsylvania. This presentation is part of the ASHP-ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures for this presentation are displayed on the slide. And these are the learning objectives for our time together today. So we have a lot of material to cover when we talk about the lymphomas. It's a very broad topic, so this slide here is kind of like a roadmap of what we'll be discussing. First, we'll start off with non-Hodgkin's lymphoma, and we'll review indolent non-Hodgkin's lymphoma with follicular lymphoma as our main topic. We'll discuss diffuse and aggressive non-Hodgkin's lymphoma, discussing diffuse large B-cell lymphoma and mantle cell lymphoma. We'll also cover Burkitt's lymphoma as our example of a highly aggressive lymphoma, and we'll then cover the T-cell lymphomas. We'll also do a little bit of Hodgkin's lymphoma, both localized and advanced disease. So we'll start off with the non-Hodgkin's lymphoma, focusing first on B-cell non-Hodgkin's lymphomas. Let's start off with a patient case. Our first audience response question. OG is a 67-year-old male with newly diagnosed symptomatic follicular lymphoma. He has stage 2B bulky grade 2 disease, but he has no significant pertinent medical history. Which of the following would be the most appropriate option for this patient at this time? Is it A, radiotherapy, B, BR times 6 cycles, C, Obinutuzumab, or D, CHOP times 8 cycles? And I'll give you a minute to think about this. So of the choices listed here, the most appropriate for this patient is answer B, bendamustine and rituximab times 6 cycles. This patient is not a candidate for radiotherapy alone because he has bulky and symptomatic disease. Obinutuzumab is not currently recommended as a single agent in the frontline setting. And although CHOP may be a possibility, the number of cycles is certainly questionable. And in 2021, we would certainly add an anti-CD20 monoclonal antibody for a follicular lymphoma. So again, the most appropriate response on this slide is BR times 6 cycles. So let's start off with a review of indolent or low-grade non-Hodgkin's lymphoma, and we're going to use follicular lymphoma as our example here. This is the second most common type of non-Hodgkin's lymphoma, and it accounts for about a quarter of all newly diagnosed cases. And again, follicular lymphoma being the most common indolent version of this disease. This is a disease of older patients, and our goal of therapy is palliation because very few patients are able to be cured with therapy, regardless of their stage. Now, with that said, many patients can go years without needing treatment, so sometimes our most important question is when to start. How you would decide if it's time to initiate therapy in a patient with an indolent lymphoma are listed for you here. So things like recurrent infections or symptomatic disease, threatened end organ function, bulky disease, or steady progression over the past 6 months. And finally, the patient's preference in this situation. For patients who do require therapy, we try to stratify them into one of 3 categories. So the first would be stage 1 and 2, non-bulky disease, and grade 1 or 2 under the microscope. The second would be stage 1 and 2, bulky disease, or stage 3 and 4, with grade 1 or 2 under the microscope. And finally, stage 1 through 4 with a grade 3A or 3B under the microscope. So we'll review each of these individually. For patients who have stage 1 or 2 non-bulky disease with grade 1 or 2 under the microscope, the standard of care is actually radiotherapy alone. You can see here this is a study that was done in 1996 that showed with administering radiotherapy alone to 177 patients with stage 1 or 2 follicular lymphoma had survival of up to 20 years with relapse-free rates approaching 37%. So again, in these early stage favorable diseases, if you want to initiate therapy, it's very likely going to be radiotherapy alone and not a pharmaceutical treatment. For patients who have a little more advanced disease, so this would be stage 1 and 2 bulky disease, or stage 3 and 4, grades 1 or 2 under the microscope, we have a whole host of possibilities here. So what you can gather from this is chemoimmunotherapy. So chemotherapy in combination with an anti-CD20 monoclonal antibody, either Obinutuzumab or Rituximab. So bendamustine, CHOP, or CVP in combination with either Rituximab or Obinutuzumab. So essentially 6 different options here, as well as the options of the chemotherapy-free regimen, Lenalidomide and Rituximab, or if the patient has a low tumor burden or is frail, Rituximab alone. So the recommendation for BR compared to the old standby of R-CHOP was demonstrated in the STILL NHL-1 study, which was a phase 3 trial that randomized over 500 patients with stage 3 or 4 indolent or mantle cell non-Hodgkin's lymphoma to either BR or R-CHOP. And the long-term follow-up results of the study were recently reported. You can see here that the progression-free survival as well as the time to next treatment heavily favored the BR arm. However, there was a higher incidence, a statistically significantly higher incidence of grade 3 or 4 neutropenia with R-CHOP, and BR was associated with lower incidence of serious adverse effects as well as a similar incidence of secondary malignancies. So given its greater efficacy and better safety profile, this is definitely a popular regimen. The trial that cemented Obinutuzumab as a place in therapy in the treatment of follicular lymphoma was in a trial called Gallium. So this was a trial of Rituxan-based chemotherapy compared to Obinutuzumab, or what we call G-based chemotherapy, given its brand name, in patients with newly diagnosed follicular lymphoma. So the combination of chemotherapy was up to the investigator. So patients could receive either CHOP, CVP, or bendamustine, as well as one of those 2 monoclonal antibodies, with a primary endpoint of investigator-assessed progression-free survival. So the results of the Gallium study are shown here, and my impression of this study was that the results are essentially a wash. There was a statistically significantly greater progression-free survival at 3 years for patients who received Obinutuzumab. However, there was also higher instances of grade 3 or higher adverse events, grade 3 or higher infusion-related reactions, and grade 3 or higher infections in patients who received Obinutuzumab. So although it may have worked slightly better, it was also more toxic. You'd also need to give serious consideration to cost in this scenario, given the availability of Rituxan biosimilars now. One sort of unique finding of the Gallium study, however, was that there were more deaths in patients who received a bendamustine-based regimen than in CHOP or CVP, and this difference was irrespective of the monoclonal antibody. So regardless of whether the patient received Rituximab or Obinutuzumab, if they had received bendamustine, there were more deaths than in the other 2 combination chemotherapies. We couldn't say for sure what the cause of that increased mortality was. It was mostly infections, but other major toxicities included cardiac, neurologic, and respiratory. So again, it's difficult to interpret this, but it should certainly be considered with caution. Somewhat recently, The regimen of lenalidomide and rituximab, or the chemotherapy-free R-squared regimen, was studied in untreated advanced stage follicular lymphoma. And this randomized patients to the R-squared regimen or chemotherapy plus rituximab. The chemotherapy could be R-CHOP, R-CVP, or bendamustine and rituximab, like we saw in the Gallium study. This was a superiority trial with dual primary endpoints of complete response at 120 weeks and progression-free survival. So unfortunately, the Relevance trial did not demonstrate superiority of lenalidomide and rituximab compared to rituximab and chemotherapy in the frontline treatment of follicular lymphoma. You can see here that the p-values were not reaching statistically significant for any endpoint, including progression-free survival or overall survival. Although the Relevance trial did not meet its primary endpoints of superiority of the R-squared regimen, it certainly did show a reasonable amount of efficacy. And the main benefit is this is a chemotherapy-free regimen that may be preferable in frailer patients. So it's not a category 1 recommendation like some of the other regimens that we've just discussed. However, it's considered a category 2A in the current NCCN guidelines. And our final category of the frontline treatment of follicular lymphoma, any stage, grade 3A or 3B. The guidelines would suggest that these patients should be treated as if they had diffuse large B-cell lymphoma, which means that most of them will receive R-CHOP. The designation of grade 3 is an area of controversy. The distinction between grade 3A and 3B is certainly very difficult to make and hasn't been shown to be clinically significant. So I would guess that this type of disease will be considered an area of controversy and not testable on the board exam. However, if this would appear, your best guess is to treat it like diffuse large B-cell lymphoma and recommend R-CHOP. So to summarize what we've just said, for follicular lymphoma or indolent lymphoma, stage 1 and 2, non-bulky, grades 1 and 2, if therapy is necessary at all, radiotherapy alone is preferred. For stage 1 and 2 bulky disease, or stage 3 and 4, with grade 1 or 2 under the microscope, you're going to give traditional chemotherapy in combination with some anti-CD20 monoclonal antibody, either rituximab or obinutuzumab, all as category 1 recommendations. You could also use the chemotherapy-free recommendation, R-squared, lenalidomide and rituximab. And if the patient was frail and had a low tumor burden, you could use rituximab alone. Stage 1 through 4, but grade 3A or 3B is controversial. However, these patients are usually treated like diffuse large B-cell lymphoma and would be recommended to receive R-CHOP. So on to our next audience response question. Our patient completed 6 cycles of BR and achieved a complete response. So which of the following is the most appropriate option for the patient at this time? Is it A, ofatumumab monthly for 1 year, B, lenalidomide daily, C, rituximab monthly for 1 year, or D, rituximab every 2 months for 2 years? The most appropriate answer here is answer D, rituximab every 2 months for 2 years. So there's no current recommendations for ofatumumab maintenance therapy. Likewise, for follicular lymphoma, there's no recommendation for lenalidomide as the maintenance therapy. So that leaves you with rituximab, and the recommended schedule is here, every 2 months for 2 years. The role for maintenance therapy in follicular lymphoma was based off of a trial called PRIMA. So you can see here, we took about 1,200 patients with untreated follicular non-Hodgkin's lymphoma and randomized them to several chemotherapy arms. If they achieved a complete response or partial response, they underwent a second randomization to rituximab maintenance, which in this trial was every 8 weeks or every 2 months for 2 years, compared to observation. The results of the PRIMA trial showed that the median progression-free survival as well as the 10-year progression-free survival heavily favored the patients who received rituximab maintenance compared to observation. There were very few adverse events that led to discontinuation. Although this trial did not show a difference in overall survival between the two arms, the use of rituximab maintenance is currently recommended for patients with follicular lymphoma who respond to their first-line chemoimmunotherapy regimen. So what about the use of Obinutuzumab as maintenance therapy for patients with follicular lymphoma? This is currently a Category 2A recommendation compared to the recommendation for rituximab maintenance, which is Category 1. The reason for the lower recommendation is that trials have only been conducted in patients who received Obinutuzumab as part of their frontline chemoimmunotherapy. So essentially, the recommendation is not to switch between the anti-CD20 monoclonal antibodies for maintenance therapy. If you led off with rituximab, you would continue that in the maintenance setting, and likewise with Obinutuzumab. Unfortunately, follicular lymphoma is incurable, and all patients will eventually relapse. So when that happens, you have many possibilities of what to do next. You could use chemoimmunotherapy with either of the anti-CD20 monoclonal antibodies. You could use lenalidomide and rituximab, the R-squared chemotherapy-free regimen. If it's a second or greater relapse, you could use the PI3K inhibitors, idelalisib, copanlisib, and duvelisib. And in certain circumstances, specifically an EZH2 mutation, you could use the new oral agent tazemetostat. And I have that detailed in greater information in your handout. I also want to give you the hint that I'm recording this presentation in February of 2021, and very early this month, another agent was approved for the treatment of relapsed or refractory follicular lymphoma as well as marginal zone lymphoma, and that's called umbralisib. That information will not be in your handout because it's so new, so I strongly encourage you to read the prescribing information as well as the associated studies for that new agent, because that's a great question to ask on the boards. Okay, changing gears now into diffuse large B-cell lymphoma. Our third audience response question. We have a 63-year-old male recently diagnosed with stage 4B diffuse large B-cell lymphoma. The CT scans revealed 2 involved lymph nodes, both of which are greater than 10 centimeters in diameter. So which of the following is the most appropriate treatment option for this patient at this time? Is it A, R-CHOP times 3 cycles plus radiation therapy, B, R-ICE times 3 cycles, C, R-CHOP times 6 cycles plus or minus radiation therapy, or D, G-CHOP times 6 cycles plus or minus radiation therapy? So the most appropriate answer here is answer C, R-CHOP times 6 cycles plus or minus radiation therapy. I wish I could tell you there was a lot of new information in diffuse large B-cell lymphoma, but spoiler alert, you guys, it's still R-CHOP. Given the fact that this patient has stage 4B disease as well as very large and bulky tumors, he would certainly need 6 cycles, and the decision for radiation therapy would be made by radiation oncology, but it may be a possibility. The choice of 3 cycles is not appropriate. R-ICE is not indicated in the frontline setting, and G-CHOP was actually a negative study in diffuse large B-cell lymphoma, so those answers are not appropriate. So diffuse large B-cell lymphoma is actually the most common lymphoid neoplasm in adults. And because it's an aggressive lymphoma, it's much more likely to be sensitive to chemotherapy, and therefore our goal of treatment for all patients is cure. There's been a lot of interest lately in what's called the cell of origin, or COO. So if you read any of the non-Hodgkin's literature, they'll mention things like the activated B-like diffuse large B-cell lymphoma or germinal center B-like diffuse large B-cell lymphoma. The data seems to be that germinal center B-like diffuse large B-cell lymphoma has a better response and therefore better outcomes to conventional chemotherapy. However, this does not influence our choice of first-line treatments at this moment in time. There may be a time that we choose different frontline therapy based on the cell of origin, but as of this moment, it does not influence what we're going to choose. So similar to follicular lymphoma, we're going to stratify our diffuse large B-cell lymphoma when they are newly diagnosed into one of three categories. Stage 1 and 2, non-bulky disease, Stage 1 and 2, bulky disease, and any Stage 3 or 4 disease. So the treatment of diffuse large B-cell lymphoma is largely unchanged over the past 2 decades. But what we know is that these patients can be cured with a combination of chemotherapy. The combination that we most likely choose is CHOP, so cyclophosphamide, doxorubicin, vincristine, and prednisone. And using CHOP alone achieved a 5-year overall survival in 30 to 40% of patients in the original trials, with a cure rate of about 30%. But adding the anti-CD20 monoclonal antibody rituximab to CHOP resulted in superior event-free survival at all time points. So as I mentioned in the audience response question, the choice of therapy for diffuse large B-cell lymphoma is always going to be R-CHOP. It's just a question of how many cycles. So for Stage 1 and 2, non-bulky disease, we would recommend R-CHOP times 3 cycles and radiation therapy to the affected areas. For Stage 1 and 2, but bulky disease, we would recommend R-CHOP for 6 cycles, plus or minus radiation therapy. And for any Stage 3 or 4 disease, we would recommend R-CHOP for 6 cycles, plus or minus radiation therapy at the discretion of radiation oncology. What is different in diffuse large B-cell lymphoma than follicular lymphoma is that there is no role for maintenance rituximab. So once the patients have completed their R-CHOP, they move into an observation phase. And as I mentioned, Obinutuzumab is not recommended for the treatment of diffuse large B-cell lymphoma. The regimen of G-CHOP was actually not found to be superior to R-CHOP, and therefore it's not recommended. I just wanted to remind you that NCCN does make recommendations for the treatment of diffuse large B-cell lymphoma in the elderly or frail patients who may not be candidates for R-CHOP. So I have some of the alternative regimens listed on the slide for you here. The specific agents are spelled out within your handout, and how you would choose would be basically what you think the patient can tolerate. So again, I refer you to the handout for more information, but just a reminder that some alternatives do exist. On the flip side, there's certainly a lot of interest in increasing the dose intensity of R-CHOP in order to improve the response rates as well as the survival rates. So some possibilities here would be to maintain or increase the dose intensities of anthracyclines, to change the infusional schedule and increase the dose of other agents within R-CHOP, such as the dose-adjusted R-EPOCH regimen, or to increase the dose intensity by changing the treatment interval, so changing from an every 21-day schedule to an every 14-day schedule. So the most popular of those options is to increase dose intensity using the dose-adjusted R-EPOCH regimen. And this was compared to R-CHOP in what's known as the CALGB or Alliance trial. This was over 500 patients with previously untreated diffuse large B-cell lymphoma that were randomized to either R-CHOP or dose-adjusted R-EPOCH, with the primary endpoint of event-free survival, with secondary endpoints of response rates, overall survival, and safety. The results of the CALGB and Alliance study were recently published, and they were a bit of a surprise. So you can see here that the progression-free survival and overall survival at 5 years was not different between the groups. Not surprisingly, the toxicities of dose-adjusted R-EPOCH were statistically significantly greater. So more thrombocytopenia, febrile neutropenia, and peripheral neuropathy, which all led to a greater incidence of treatment discontinuation in the dose-adjusted R-EPOCH arm. Also surprisingly, subgroup analysis did not reveal a difference in the 5-year event-free survival for any group. So what do we do with these results? Well, as I said before, on the whole, it's still R-CHOP. This study did not provide compelling evidence that dose-adjusted R-EPOCH should be the standard of care for all patients with diffuse large B-cell lymphoma. It's actually now a Category 2A recommendation as opposed to the Category 1 recommendation of R-CHOP. The little asterisk here, though, is that the selection of dose-adjusted R-EPOCH may be appropriate in more aggressive subtypes of diffuse large B-cell lymphoma, which we'll go over in the upcoming slides. The niche for dose-adjusted R-EPOCH and other more intensive chemotherapy regimens is very likely in what we now call high-grade B-cell lymphoma. So these would be patients with diffuse large B-cell lymphoma who have a rearrangement in the MYC region, in addition to rearrangements in BCL2 and or BCL6. So these rearrangements provide a distinct survival advantage to these malignant cells. The MYC rearrangement is an oncogene, and the BCL2 and 6 rearrangements are tumor suppressor genes. So rearrangements in either of those areas lead to a highly aggressive clinical course and very poor clinical outcomes. You may know these diseases as double hit or triple hit lymphomas, but recently we've been calling them the blanket statement high-grade B-cell lymphoma. And these patients are the ones that may be more appropriate, again, for dose-adjusted R-EPOCH or R-hyper-CVAD or other more intensive strategies. Which of those more intensive strategies is still up for debate, but what we do know is that R-CHOP is probably not enough therapy for patients with high-grade B-cell lymphoma. And there's more information on your handout on this topic, so I'd refer you there. I also wanted to briefly touch on the risk of central nervous system involvement with diffuse large B-cell lymphoma. The risk is low, but it's still possible. And there are some very useful scores that can estimate the patient's risk. So in your handout, I have detailed what's called the CNS IPI score, International Prognostic Index score. If the patient is determined to be at high risk for CNS involvement, the best prophylaxis and treatment strategies are not known, but the guidelines would suggest intrathecal methotrexate, systemic methotrexate, or cytarabine for prophylaxis. And for treatment, systemic methotrexate plus or minus intrathecal methotrexate or cytarabine. So despite the impressive responses with R-CHOP and other dose-intensive strategies like dose-adjusted R-EPOCH, about 40% of patients with diffuse large B-cell lymphoma will experience treatment failure, and this often occurs early in their treatment course. The goal of treatment in a relapsed diffuse large B-cell lymphoma patient is still to cure them. Your strategy is going to depend on whether they're proceeding to an autologous stem cell transplant, or if they're not a candidate and you only need to treat them with chemotherapy alone. So if your goal is to get this patient to an autologous stem cell transplant, your second-line chemotherapy should include agents that will spare the stem cells. So these would be regimens like R-ICE, R-ESHAP, and R-DHAP, as well as some others. If they're not a candidate for an autologous stem cell transplant, you actually have many more choices for their chemotherapy regimen because you're not thinking about preserving those stem cells for collection later. So chemotherapy regimens would include the same ones that I just mentioned, as well as R-GEM-OX, other regimens that are listed in your handout. The new agent, tafasitamab and lenalidomide and rituximab, or selinexor, which is only indicated after at least 2 lines of systemic therapy. In addition, there are several newly approved agents that are indicated in the relapse and refractory diffuse large B-cell lymphoma setting. The first of these is a monoclonal antibody drug conjugate called Obinutuzumab vedotin. So this is a monoclonal antibody that's anti-CD79B, which is conjugated to a cytotoxin, MMAE. This was approved in June of 2019 in combination with bendamustine and a rituximab product. Notice they didn't say which particular form of rituximab. In adult patients with relapsed or refractory diffuse large B-cell lymphoma after at least 2 prior therapies. NCCN further narrowed their recommendation to limit this to transplant-ineligible patients only. The approval for Obinutuzumab vedotin was based on a phase 2 study that compared Obinutuzumab, bendamustine, and rituximab to bendamustine and rituximab alone in patients with relapsed or refractory diffuse large B-cell lymphoma who were not eligible for stem cell transplant. And you can see here that there was a statistically significantly greater complete response rate in the patients who received Obinutuzumab. Likewise, there was a longer duration of response, progression-free survival, and overall survival with the Obinutuzumab vedotin. Adverse effects, though, were significant. Serious adverse effects occurred in up to 64% of patients, most often from infection. We also saw some peripheral neuropathy from the MMAE component of the drug, as well as myelosuppression. Also recently approved in the same setting is tafasitamab, which is a CD19-directed cytolytic antibody. This was approved in July 2020 in combination with lenalidomide for relapsed or refractory diffuse large B-cell lymphoma in patients who are not eligible for an autologous stem cell transplant. This was approved off of a single-arm trial that showed the overall response rate is about 55%. And the most common adverse effects were myelosuppression, diarrhea, peripheral edema, and respiratory tract infection. Also recently approved for the treatment of relapsed diffuse large B-cell lymphoma are several CAR-T products. These are axicabtagene ciloleucel, or Yescarta, and tisagenlecleucel, or Kymriah. Oh, you guys have been practicing those. These are both approved for the treatment of relapsed or refractory diffuse large B-cell lymphoma, high-grade B-cell lymphoma, and transformed follicular lymphoma after 2 or more systemic therapies, so a little later in the patient's course. The individual studies are detailed in your handout, but what I'd ask you to understand is that responses were seen in all subgroups in these studies. So they're currently recommended in patients who achieve a partial response following second-line therapy and for disease relapse after achieving a complete response to second-line therapy. The management of the toxicities of CAR-T therapy are detailed very nicely in both the acute leukemia and the pediatrics materials, so I certainly would stress that you should look at those. So now let's think about some supportive care issues for the treatment of non-Hodgkin's lymphoma. Our fourth audience response question. Our patient will be initiating rituximab. His pre-screening workup revealed hepatitis B surface antibody positive, hepatitis B surface antigen negative, and hepatitis B core antibody negative. His LFTs are within normal limits, so which of the following is the most appropriate course of action for this patient? A, initiate rituximab as scheduled. B, reschedule rituximab and administer the hepatitis B vaccine. C, eliminate rituximab and initiate entecavir. Or D, initiate lamivudine and proceed with rituximab. So the correct answer here is A, initiate rituximab as scheduled. This patient's pre-screening workup shows that he's had the hepatitis B vaccine already. He has not had hepatitis, nor does he currently have hepatitis B. So you could go ahead and proceed with your plans. If the patient needed anti-hepatitis B therapy, it would likely be with entecavir and not lamivudine. And so we'll review that in the next slide. So for patients who are receiving rituximab or any anti-CD20 monoclonal antibody, it's recommended to do a baseline hepatitis panel before initiating therapy. The panel should include the hepatitis B surface antigen as well as the hepatitis B core antibody. If it turns out that the patient has or had a hepatitis B infection, the treatment of choice would be entecavir instead of lamivudine due to concerns of resistance in the United States. You could still proceed with rituximab therapy, but you would need to monitor the viral load and continue the prophylaxis that you had chosen for up to 12 months after the completion of rituximab. Once again, this is detailed much more deeply in your handouts, and I, as a clinician, would certainly recommend a consult to the liver specialists in this situation as well. Now, a few slides about the specific agent rituximab and its similar products. There is a product called Rituxan Hycela, which is a combination of the monoclonal antibody and hyaluronidase. This is approved for use in CLL, diffuse large B-cell lymphoma, and follicular lymphoma. This product is a subcutaneous injection, but should only be initiated after the patients have received and tolerated at least one full dose of traditional IV rituximab. Pre-medications are required, and I want to draw your attention to the fact that the doses and the times of administrations and the vial sizes are different between CLL and lymphomas. So please use caution. And again, please refer to this information in your handout so you understand the differences between the disease states. In terms of rituximab biosimilars, I have 2 of them listed for you here, but there's actually 3 as of this moment. Third approval after these slides were due. It's worth noting that the approval to all of these agents was granted without the extrapolation to all other indications for rituximab, including in CLL and other disease states. Likewise, this was approved as a biosimilar, not an interchangeable product. Your institution may have different policies, but what is recommended is that alternating between the reference product and the biosimilar is not recommended. And ideally, patients should remain on the same product that they started on throughout their entire treatment course. Again, your institution may have different policies, but I'm pointing out to you here what the recommendations are. Finally, the NCCN guidelines do include recommendations for bone health in patients with non-Hodgkin's lymphoma who received corticosteroids as part of their treatment regimen. It's recommended that patients increase their calcium intake and potentially start supplementation. Levels of vitamin D should be monitored and replaced if necessary. And after 1 year of the completion of therapy, an evaluation of the bone mineral density should be performed. If the patient is osteoporotic, you would use a FRAX assessment to determine future therapy. And if drug therapy is warranted, you could consider any number of treatments, hormone replacement therapy, bisphosphonates, or denosumab, based on the individual patient's presentation and preference. So now we're going to switch gears and talk about mantle cell lymphoma, which is actually a very small portion of all the newly diagnosed cases of non-Hodgkin's lymphoma, but it has some unique properties. Some references classify mantle cell lymphoma as an indolent lymphoma, while others consider it an aggressive one. But the bottom line is that it possesses the worst characteristics of both of those subtypes. It has an extremely aggressive disease course, and with conventional chemotherapy, this is considered to be incurable. So just like the other lymphomas, we would try to stratify the patients before we decided on their therapy. Some patients are classified as stage 1 and 2 non-bulky, but this is extremely rare. I kind of feel like these patients are unicorns. There might be some out there, but I've never seen one. In those cases, the patients could receive radiation therapy alone or a combination of chemoimmunotherapy plus and minus radiation therapy. Most patients are going to have advanced disease at presentation, so either stage 2 bulky or stage 3 or 4. Unfortunately, most of these patients are going to be elderly, so how we decide to treat them needs to consider their comorbid conditions, and whether we want to be aggressive or less aggressive with their initial choice of therapy. I also want to call out to you on this slide some of the terminology that we're using here. In mantle cell lymphoma, we consider induction and consolidation chemotherapy, almost like a leukemia. So for a patient with mantle cell lymphoma who is a candidate for aggressive therapy, the induction regimens are listed for you here. Again, these look like those high-grade lymphomas. These are more than CHOP. R-CHOP alternating with R-DHAP, the Nordic regimen, or R-Hypercvad, again, which are all detailed in your handout. These patients, after the completion of their induction therapy, would move into consolidation with an autologous stem cell transplant, followed by maintenance rituximab every 8 weeks for 3 years, and that is a Category 1 recommendation. So this slide right here is about 3 years worth of very intensive and aggressive chemotherapy. Most mantle cell lymphoma patients will not be candidates for this approach. Most mantle cell lymphoma patients will require less aggressive therapy than what I just said. So these patients will still receive induction and consolidation, and I have some of the potential induction regimens listed for you here, but the one that's emerging as the favorite is VR-CAP. Once that's completed, the patients would then move into consolidation, again with rituximab every 8 weeks, but this time until progression or intolerance. And that's a Category 1 recommendation if the patient receives R-CHOP. However, we're extrapolating it to pretty much all patients in clinical practice. So to touch on the VR-CAP regimen, it's essentially R-CHOP, but we have replaced the vincristine with the proteasome inhibitor bortezomib. So rearranging all the letters, that spells VR-CAP. And its efficacy was shown in the LYM 3002 study, where we compared VR-CAP to traditional R-CHOP in almost 500 patients with newly diagnosed mantle cell lymphoma, all of whom were not candidates for stem cell transplant. So again, less aggressive therapy. The primary endpoint was progression-free survival as assessed by an independent review committee. The results of the LYM 300 study are shown for you here. You can see that median progression-free survival, median time to progression, and median overall survival all statistically significantly favored the VR-CAP regimen as compared to R-CHOP. There was a higher incidence of grade 3 and 4 adverse effects in the VR-CAP arm, but these were mostly thrombocytopenia and peripheral neuropathies, which the investigators felt were manageable with transfusions and medications. So based on these results, bortezomib alone actually received an FDA approval in the setting of mantle cell lymphoma, but we often use it in combination with other agents, such as in the VR-CAP regimen. So as we mentioned, unfortunately, mantle cell lymphoma is not curable with conventional chemotherapy, so disease relapse is nearly universal. What you do at that point is somewhat unclear. If the response to their prior chemoimmunotherapy regimen was short, you could choose some of the small molecule inhibitors that we have here. So your Bruton tyrosine kinase inhibitors, lenalidomide, or venetoclax. However, the definition of short is not well defined. On the flip side, a patient with relapsed mantle cell lymphoma who had an extended response to their prior chemoimmunotherapy could use any of the small molecules we already discussed, as well as some additional options like bendamustine plus or minus rituximab or bortezomib plus or minus rituximab if they hadn't previously been given. There's also a CAR-T product that has been approved in the setting of relapsed mantle cell lymphoma, and that's brexucabtagene. But again, this is only given after chemoimmunotherapy and one of the Bruton tyrosine kinase inhibitors, so a little further along in the patient's course. Very briefly, I wanted to discuss the Bruton tyrosine kinase inhibitors in the treatment of mantle cell lymphoma. If you've already listened to the chronic leukemias recording, you know that I went on and on about these agents for CLL, so I just wanted to call out the differences here. First, ibrutinib for the treatment of relapsed mantle cell lymphoma has an FDA approval in this setting once the patients have received at least one prior therapy. However, the dose is different than what we use in CLL. So in mantle cell lymphoma, it's 560 milligrams a day compared to 420 for CLL. You could also use the Bruton tyrosine kinase inhibitor acalabrutinib in this setting. This is considered to be a second-generation BTK inhibitor, which potentially has less interaction with platelet activity and other off-target receptors. Again, I have detailed this agent very thoroughly in the CLL materials, so I'll refer you there. The new approval in this setting is zanubrutinib, or Brukinsa, which was approved in November of 2019 for relapsed mantle cell lymphoma after at least one prior therapy. This was approved based on 2 small trials that showed an overall response rate of around 84%, with a median duration of response of about 18 months. What is very unique about this agent is that its approval was actually for 2 different dosage schedules, so 160 milligrams PO BID or 320 milligrams PO daily, and those are both recommended for the treatment of relapsed mantle cell lymphoma. So clinician's choice. I certainly think we would see more of the daily administration schedule, but just a unique little quirk about this agent is that it actually has 2 schedules approved. And finally, a CAR-T product has been approved for relapsed mantle cell lymphoma. This is brexucabtagene autoleucel, or Tecartus, which was approved in July 2020 for relapsed or refractory mantle cell lymphoma after being previously treated with an anthracycline or bendamustine, as well as an anti-CD20 monoclonal antibody and a BTKI, so pretty heavily pretreated patients. You can see this was a single-arm trial of only 74 patients, but the overall response rate was an impressive 87%. And just like all the other CAR-T products, there's a REMS program due to the risk of cytokine release syndrome and neurologic toxicity. And again, I refer you to both the acute leukemias and the pediatrics information for how you would manage those specific toxicities. And our last B-cell lymphoma is Burkitt's lymphoma, which is a highly aggressive non-Hodgkin's lymphoma. Some references say this is the fastest growing human tumor, and we are very certain that if patients are left untreated, their life expectancy is only weeks. This is somewhat uncommon in adults. There's only about 1,200 patients diagnosed every year. It's much more common in children, and again, I refer you to the pediatrics material for treatment of this disease in children. There are 3 different variants of Burkitt's lymphoma, but we're only going to cover the sporadic form here. So because this is such a rapidly dividing tumor, it's going to be very sensitive to chemotherapy. So our goal of treatment in all patients is cure. However, it's so rapidly dividing that mutations occur frequently. So CHOP or R-CHOP is not adequate treatment. All of the regimens that I'm about to show you have numerous agents to prevent resistance. So for the rare patients that have low-risk disease, you can see here some treatment options include Codox-M, dose-adjusted R-EPOCH, or R-Hypercvad, alternating with methotrexate and Ara-C. And again, I have these much more detailed in the handout. Most patients with Burkitt's lymphoma are going to have high-risk disease, especially in an adult. So your treatment regimens here are even more aggressive. Some examples would be Codox-M alternating with IVAC plus or minus rituximab, again, dose-adjusted R-EPOCH, and R-Hypercvad alternating with methotrexate and Ara-C. Burkitt's lymphoma also loves the brain. So as opposed to diffuse large B-cell lymphoma, where you may need to consider CNS prophylaxis, all patients with Burkitt's lymphoma need to receive CNS prophylaxis in addition to all of the systemic chemotherapy that we just mentioned. Likewise, this tumor is so rapidly growing that tumor lysis syndrome is very possible, and I would refer you to the acute leukemias materials for treatment and prevention of that particular disease state. For the patients with relapsed Burkitt's lymphoma, there is no standard of care. The guidelines would actually say that a clinical trial is preferred in this situation, which is certainly never a good option. My mentor likes to say that Burkitt's lymphoma is one and done. The large number of patients will be cured on their first go-round, and then they're done in a good way. But for patients who are not cured on the first go-round, they're also done, but in the opposite direction. Some potential regimens are listed for you here, but again, there is no definitive standard of care in this setting. So now we're going to close the book on the B-cell lymphomas, but still stay under the umbrella of non-Hodgkin's lymphoma and discuss the treatment of T-cell lymphomas. We'll lead off with an audience response question. We have a 61-year-old African-American male with newly diagnosed CD20 negative, CD30 negative, ALK1 immunostaining negative, stage 4 peripheral T-cell lymphoma, not otherwise specified. Which of the following is the most appropriate first-line treatment for this patient? Is it A, brentuximab vedotin plus CHP, B, R-CHOP, C, CHOP, or D, belinostat? So of the choices here, the most appropriate one is answer C, or CHOP. This patient is CD20 negative, which means he's not a candidate for rituximab in answer B. Likewise, he's CD30 negative, which means he's not a candidate for brentuximab in answer A. And belinostat is only used in the relapsed and refractory setting at this time. We'll start off our discussion of the T-cell lymphomas with the cutaneous form of the disease. This is often referred to as mycosis fungoides or Sézary syndrome. In the early stages of the disease, therapy is directed at the skin itself. So this would be topical steroids, topical chemo, topical retinoids, or local radiation or phototherapy. For more advanced stages, or after a patient has failed multiple skin-directed therapies, we can move into systemic treatment. There's no standard of care here, so this would be things like interferons, retinoids, or HDAC inhibitors. And in severe and refractory cases, we can use traditional chemotherapy. But again, there is no recommended regimen or standard of care. Cutaneous T-cell lymphoma has its own monoclonal antibody, and that's called mogamulizumab. This is approved for adults with relapsed or refractory mycosis fungoides or Sézary syndrome after at least one prior systemic therapy. This monoclonal antibody has a unique mechanism of action. It selectively binds to the CC chemokine receptor type 4. And when it was compared to vorinostat in a phase 3 study called Maverick, it showed superior progression-free survival, but also, and maybe more importantly, statistically significantly greater in patient-reported outcomes. So these patients reported less itching, less changes in their skin quality, some more things that may be important to a patient with this devastating type of disease. And that leads us into our next topic, which is the supportive care of patients with cutaneous T-cell lymphoma. I think this is probably more important than learning the drugs in this particular class, is just how to take care of these patients that have such profound symptoms. So itching is a very commonly reported complaint of these patients. Things like topical moisturizers and emollients, as well as systemic antihistamines or gabapentin can be used. And for refractory symptoms, you could use things such as aprepitant, naltrexone, Remeron, or other SSRIs. These patients are very prone to infections, both gram-positive and gram-negative. These patients can be advised to actually take baths in diluted bleach water. And we should consider prophylaxis for both HSV and VZV in these patients. And our last non-Hodgkin's lymphoma topic, peripheral T-cell lymphoma. This disease arises from the mature T cells of post-thymic origin. And this is very uncommon compared to B-cell lymphoma. You can see here it's only about 10% of all cases of non-Hodgkin's lymphoma. There's numerous subtypes, but the most common one is called not otherwise specified, right? Real helpful there. but the prognosis is also poor compared to B-cell non-Hodgkin's lymphoma. There are lower response rates and they're less durable, very likely because we can't use B-cell directed monoclonal antibodies like rituximab in this patient population. The first-line treatment of peripheral T-cell lymphoma is going to be an anthracycline-based chemotherapy regimen. And you can see here, these are variations of CHOP. Again, rituximab is not going to be given because T-cells are not typically CD20 positive. But if the patient is CD30 positive, you could use the combination of brentuximab as well as cyclophosphamide, doxorubicin, and prednisone as a Category 1 recommendation based on the Echelon 2 study. The treatment of relapsed peripheral T-cell lymphoma is based on whether the patient is proceeding to a stem cell transplant or not. I have some of the more recently studied agents listed for you here. You can see we have options like HDAC inhibitors and antifolates. You could also consider single agent or combination chemotherapy if the patient is not a candidate for stem cell transplant. So closing the book on the non-Hodgkin's lymphomas, and now moving to our last topic, Hodgkin's lymphoma. I'm so lucky, you guys. I get all the good topics. So our next audience response question. We have a 24-year-old female who presented to the lymphoma clinic with fatigue, fevers, and pruritus. She was eventually diagnosed with stage 3B bulky classical Hodgkin's lymphoma. Which of the following would be the best treatment option for this patient at this time? Is it A, CHOP times 6 cycles plus involved site radiation therapy? B, ABVD times 2 cycles plus involved site radiation therapy? C, ABVD times 2 cycles followed by AVD for 4 cycles? Or answer D, Stanford 5 times 8 weeks? So of the choices that I gave you here, the most appropriate one is ABVD times 2 cycles followed by AVD for 4 cycles, or answer C. Hopefully you recognize that CHOP is not an appropriate regimen for Hodgkin's, and likewise, Stanford 5 has really fallen out of favor in the past couple of years. Answer B is not appropriate because the patient has stage 3B bulky disease, so she may or may not be a candidate for radiation, but 2 cycles of chemotherapy only is not appropriate for stage 3B. So as I said, I'm so lucky. I get to do all the fun topics. Hodgkin's lymphoma is very highly curable, and our goal of treatment in all patients is cure. You can see here that the 5-year survival is greater than 80%, and the cure rates are so high that we now think about late treatment effects being the most devastating portion of this cancer as opposed to the cancer itself. There are 2 main types of Hodgkin's lymphoma. First is called classical Hodgkin's lymphoma, which is characterized by the presence of those Reed-Sternberg cells, those 2-eyed owls, or the double nuclei cells, if you've ever seen pictures of them. Classical Hodgkin's lymphoma is further divided into 4 subtypes, which are listed for you here. But the subtype of classical Hodgkin's lymphoma doesn't really dictate choice of treatment. It's going to be more based on the stage. The second subtype is called nodular lymphocyte predominant Hodgkin's lymphoma, which lacks those Reed-Sternberg cells, and very interestingly, often expresses CD20 positive. So these patients may be candidates for rituximab. So now thinking about classical Hodgkin's lymphoma. A newly diagnosed patient is going to be classified into one of 4 groups. And you can see here, these would be stage 1A and 2A favorable, stage 1 and 2 unfavorable but non-bulky disease, stage 1 and 2 unfavorable and bulky disease, or stage 3 and 4. In the United States, the backbone of therapy for classical Hodgkin's lymphoma is ABVD, so doxorubicin, bleomycin, vinblastine, and dacarbazine. However, in the last few years, we've been exploring some strategies to de-escalate the intensity of this therapy, trying to spare the patients from the long-term toxicities, specifically from the pulmonary toxicity of bleomycin. So this is detailed in your handout, but based on a study called Rathel and others, recommendations now are to scan the patient after 2 cycles. If the patient has an optimal response, you would de-escalate therapy, so drop the bleomycin or proceed to involve site radiation therapy. If the patient unfortunately has a suboptimal response, you could escalate therapy, so move to a different chemotherapy regimen or explore another treatment strategy. And if the patient doesn't respond at all, you would actually rebiopsy them and treat according to the results. And again, this is done to avoid long-term toxicities, as I said, mainly the pulmonary toxicity of bleomycin, but also infertility and secondary malignancies, given the age of most patients with Hodgkin's lymphoma. So on these next couple slides, I tried to visually illustrate how you would de-escalate or escalate therapy based on the results of those scans after the first 2 cycles. This is my work, folks, so please have mercy on me and your criticism. So for stage 1 and 2, favorable disease, you would lead off with ABVD times 2 cycles, and that's a category 1 recommendation. You would do a PET and CT scan, and based on the results, you could de-escalate to involve site radiation alone, drop the bleomycin and do AVD for 4 cycles, continue ABVD times 1 or 2 cycles plus or minus radiation, and if you had no response, you would rebiopsy them. For a patient with stage 1 and 2 unfavorable but non-bulky disease, again, you would lead off with 2 cycles of ABVD as a preferred regimen, do a PET and CT scan. Depending on the results, you could continue ABVD for 2 more cycles in combination with involved site radiation. You could do ABVD alone for 2 more cycles. And if the patient needed to escalate therapy, you could move up to BCOP for 2 cycles. For stage 1 and 2 unfavorable and bulky, again, you're going to lead off with ABVD for 2 cycles as a category 1 recommendation. And depending on the results of the PET and CT scans after that second cycle, you could do ABVD for 2 more cycles with involved site radiation, drop the bleomycin and do AVD for 4 cycles with or without radiation. If you needed to escalate therapy, you could move to BCOP for 2 to 4 cycles, plus or minus radiation. And again, if the patient didn't respond at all, you would rebiopsy them. Finally, for stage 3 and 4, you would lead off with ABVD for 2 cycles and scan them after the second cycle. If you were able to de-escalate therapy, you could drop the bleomycin and do AVD for 4 cycles with or without radiation. You could continue ABVD for 2 to 4 more cycles with or without radiation. And if you needed to escalate therapy, you would move to BCOP for 2 to 4 cycles with or without radiation. So I just want to remind you that this is detailed much more deeply in your handout. Likewise, I don't think that you're going to be asked to interpret the results of a PET scan or CT scan on the board exam. I think what is a more fair question is the patient has been scanned, we demonstrated a response, now what do you want to do? So you can see that ABVD is clearly the preferred regimen for the frontline treatment of classical Hodgkin's lymphoma. You may be familiar, though, with other initial treatment regimens such as Stanford 5 or BCOP, either standard BCOP or escalated BCOP. These are more popular in Europe and in other locations, but not so much in the United States. They may offer a survival advantage, but there are no direct comparisons to ABVD that we can draw any meaningful conclusions from, other than they are generally felt to be more toxic than ABVD. There's a greater incidence of myelosuppression and infection, as well as secondary malignancies. So according to the NCCN guidelines, these regimens may be considered in select patients with multiple poor prognostic features, but most patients should consider therapy with ABVD as their first-line regimen. You also might be thinking, hey, what about brentuximab vedotin? If you're in the Hodgkin space at all, you know that this agent is certainly making some noise. This is based on a trial called Echelon 1. And the trial was a randomized phase 3 trial where we substituted brentuximab vedotin instead of bleomycin. So because the regimens would have the same name, the new regimen is known as A plus AVD. So Echelon 1 was an open-label randomized phase 3 trial of A plus AVD versus ABVD in advanced classical Hodgkin's lymphoma. Kind of interesting, the primary endpoint of this trial was called modified progression-free survival as assessed by an independent review committee. This modified progression-free survival included time to progression, death, and a non-complete response and the need for subsequent anti-cancer therapy. So at the scans at the end of their treatment interval, if they didn't respond and needed further therapy, that was considered a modified PSF event. So the results of the Echelon 1 study certainly got a lot of attention in the lymphoma world. So you can see here that A plus ABVD had a statistically significantly greater modified progression-free survival at the 2-year mark by both independent and investigator review. There was a higher incidence of febrile neutropenia and peripheral neuropathy in the A plus AVD arm, but there was a higher incidence of pulmonary toxicity in the ABVD arm. However, none of those percentages for adverse effects were statistically significant. So how do you interpret this now? So the authors of the Echelon 1 trial concluded that patients who received A plus AVD had a statistically significantly increased modified progression-free survival at 2 years, and that this regimen should be considered the frontline option for classical Hodgkin's lymphoma. However, there was, shall we say, a lot of concern about the use of this modified progression-free survival as an endpoint. Likewise, if you read the study very closely, during the study, they changed the criteria to require prophylactic colony-stimulating factors in the arm of A plus AVD. So that difference in febrile neutropenia was actually tempered by the fact that some of the patients received prophylactic colony-stimulating factors in the A plus AVD arm. We can say that pulmonary toxicity may be avoided with A plus AVD. Again, small numbers of patients here that actually developed pulmonary toxicity, and the patients were only followed for 2 years. But what we do know for absolute certainty is that there is a significantly higher cost of the A plus AVD regimen. You're including a monoclonal antibody. Now you need colony stimulating factors. And the other thing to think about would be now you're using an option that we typically hold in reserve for relapse disease. So NCCN's recommendations for the A plus AVD regimen is that it's a category 2A recommendation in select patients only. Patients you may consider would be patients who have no known neuropathy at baseline, given the higher incidence of peripheral neuropathy in that treatment arm. Patients with a high international prognostic score, so 4 or greater, essentially a poor prognosis from the get-go. And if bleomycin is absolutely contraindicated in that individual patient. This is a category 2B recommendation in all other patients. So again, there may be a niche in a certain patient population, but the first line regimen is still ABVD. So if you recall, Hodgkin's disease has a bimodal pattern of distribution. We see a high incidence in adolescents and young adults, not too much in middle age, but then a higher incidence in the elderly. So I just wanted to comment on the treatment of classical Hodgkin's lymphoma in the elderly patient population. These patients have poorer outcomes than younger patients, given their disease is usually more aggressive and they already have comorbidities. Standard chemotherapy regimens like ABVD are associated with dose reductions and treatment toxicity. So the selection of first-line therapy, again, should be individualized to each particular patient. And there's more information about this in your handout. So just a few words about supportive care issues with ABVD. We've made several references to bleomycin pulmonary toxicity. So baseline pulmonary function tests and periodic ones should certainly be done. You would be on higher alert if your patient is older, received chest irradiation, or used growth factors during their chemotherapy regimen. Likewise, I want to give a shout out to smoking cessation in these patients. ABVD is associated with neutropenia, but that is not a reason to reduce the dose intensity of this regimen. Remember, nearly all patients are curable, so you would not want to change the dose intensity. And several studies have confirmed that ABVD can be safely administered without any growth factor support. So that should certainly be avoided if at all possible. As we said, most patients with Hodgkin's lymphoma will be cured. But for the few unfortunate patients who do relapse, what you do next is dependent upon whether that patient is proceeding to an autologous stem cell transplant or not. If they're going for a transplant, you would choose a chemotherapy regimen that spares the stem cells, and I have several of them listed for you here. You can see that none of them are preferred. However, prior to the introduction of the A plus AVD regimen, the preferred agent in this setting was actually brentuximab vedotin. So let's look at that data. The use of brentuximab vedotin in the relapse setting was based on a trial called ATHERA, and this was given as planned consolidation after an autologous stem cell transplant in patients who had relapsed or primary refractory Hodgkin's lymphoma and unfavorable risk factors. The primary endpoint was progression-free survival as assessed by an independent review committee. The results of the ATHERA trial are shown here. You can see that progression-free survival was greater in the brentuximab vedotin group, as well as 2-year progression-free survival. The benefit of brentuximab vedotin was seen across all subgroups, such that post-transplant maintenance with this agent in high-risk patients is now recommended. So once again, it's a little confusing if we should use this agent up front if there's the possibility of this patient needing it later. For the unfortunate patient who still needs therapy for relapse disease, we have some oral agents as well as some checkpoint inhibitors, but the optimal sequence of these agents is undefined. I have some more information about this in your handout, but there may be a greater incidence of pulmonary toxicity with the checkpoint inhibitors and what have you, so the choice here is certainly not standardized. Survivorship also plays a very large role in the treatment of Hodgkin's lymphoma. The cure rates have increased so profoundly in the last decade that treatment considerations are often thinking about long-term toxicities instead of short-term ones. So again, this is detailed in your handout, but we need to think about secondary cancers, specifically lung and breast, if the patient has received radiation. We need to consider cardiovascular disease, given the anthracycline, hypothyroidism, and fertility issues. So patients should always be treated at an oncology center for as long as possible, and all of their other healthcare providers should be aware of their treatment. One quick slide on nodular lymphocyte predominant Hodgkin's lymphoma. This is an extremely rare malignancy, so much so that we're not certain what the preferred chemotherapy regimen is. However, we often choose ABVD based on data with classical Hodgkin's lymphoma. The main thing to remember here is that nodular lymphocyte predominant Hodgkin's lymphoma usually expresses CD20, so you can use rituximab either as a single agent or in combination with ABVD. However, this type of lymphoma does not express the CD30 antigen, so brentuximab vedotin would not be an appropriate choice here. So our last audience response question. Towards the end of her ABVD infusion, this patient complains of warmth and burning around her central line site. What is the most appropriate management of this extravasation? Is it A, heat packs, B, heat packs and topical DMSO, C, ice packs and hyaluronidase, or D, ice packs and dexrazoxane? Oh, this was a hard one, you guys. 2 vesicants. In that case, the anthracycline will take priority. So the most appropriate answer here is D, ice packs and dexrazoxane. So extravasations are never good, but anthracyclines are considered to be the worst. If it was a single agent, you would apply the appropriate compresses, either cold for anthracyclines or warm for vincas and epipodophylotoxins. For anthracyclines, you could administer dexrazoxane, and other topical therapies are discussed, but they're all controversial. This is detailed a lot more in your handout, and I refer you there. I wanted to thank ASHP and ACCP for inviting me to give this presentation. It's always an honor to be part of this course. Best of luck with your studying, and thank you.